this concept of the streetlight effect. This is the tendency of, to search for an answer where we can look for it with the tools that we have. And it's not necessarily where the answer is most likely to be. And Noam Chomsky famously said something along the lines of science is a bit like this joke, because we have no other choice but to just look where the light is using the tools that we have. And this is a recurring theme in spinal CSF leak science, as well as sacral CSF leaks in particular. I think it's incredibly relevant. And so before I jump into sort of the sacral CSF leaks, the recent research that I think is important, I want to remind all of us, how far we've come in the past few years, and that there's, I think, a theme to these advancements which relate to this concept, and they are finding our blind spots. And these discoveries should remind us at every step along the way when we feel very certain about something that seems obvious, that we should remain very, very humble because we have been very, very wrong. I think that most people who are interested in this are familiar with this concept, but before 2013, if a patient presented to the hospital with a brain MRI that showed severe brain sag, obvious findings of intracranial hypotension, and the radiologist even said so in the report, but the spine MRI did not show an epidural fluid collection, and they got a myelogram, a conventional CT myelogram that did not show that dye leaving that fluid space, the subarachnoid space. They simply were told they did not have a leak because our tool did not show the answer that we were expecting. Now we have people who we see the same scenario, who might have carried several diagnoses to account for their symptoms previously, like this person, who was told they didn't have a leak in 2016, 3 years after the discovery of a CSF venous fistula, who now we simply know at the same exact level, using a different technique, a different tool, that they indeed do have a leak, that we were wrong, that they have a CSF venous fistula, they do have intracranial hypotension, and that our tools were unfit to characterize what was going on inside their body.
Hey, Andy, do
Yeah,
me a favor, jump back for 1 second. Just because we have a lot of patients here, can you go over the image on the right just a little bit to show them, whether they're physicians watching or patients, exactly what they're looking at and why the image on the right is so different from the one on the left and transforms what we understand about leaks today?
sure. So the image on the left, this one that says no leak, is a conventional CT myelogram. The patient underwent a lumbar puncture and had X-ray contrast dye injected into the CSF. They sort of rolled around on the bed, maybe did some yoga poses to allow that dye to diffuse throughout the CSF. And then they laid on their back 30 to 40 minutes later in the CT scanner with that dye, this white kind of grayish here. This is the spinal cord in the middle, diffusing homogeneously throughout the CSF space. And this structure out here is the meningeal diverticulum. We're going to get into that today. It's important for this topic of the nerve root sleeve, which has some faint dye in it here. And there's no dye, this white stuff, outside of where it should be in this picture, with the patient on their back in that fashion. This picture is actually rotated. You can appreciate that if we rotated this image counterclockwise 90 degrees, there's actually a gradient of that white. It's very, very white here, a little bit less white here, and even less so here. The patient is on their right side down. That dye is layering densely in the nerve root complex and meningeal diverticulum. And they're being imaged right after the dye was injected. That dye is rushing down towards their head from the injection point and filling this structure here, which is a vein, a paraspinal vein, segmental vein in the external epidural venous plexus that is taking away the CSF and the dye from the normal compartment. So, same part of the spine, but this structure, this vein, is normally unopacified on a non-contrast CT, just like the veins out here. But here, it's full of dye. So those are the fundamental differences between this. And of course, there's a lot more to it. But that this was one of the biggest paradigm shifts that we saw.
When you were trained, how were you trained to do a CT myelogram? The way they did it on the left or the way they did it on the right?
Well, it depended on the indication. So I did my training at UCSF, they were very interested in spinal CSF leaks. There's different reasons to get a myelogram, not only for CSF leak. For example, patients who may have a contraindication to MRI, but the surgeon may need to visualize the spinal canal and see the spinal cord and its relationship to surrounding structures, or whether it's being impinged, or whether to see the spinal canal and concurrently assess the osseous anatomy. This is a good procedure for those reasons. And so a conventional sort of delayed CT myelogram is what we would perform. But dynamic myelography, people use different words, tailored to a leak, a CSF leak that you are suspecting. This is how I was trained to do it.
Okay.
Shortly thereafter, we realized that, I showed you that first picture of a person with a brain that was sagging, that was moving downward because CSF was leaving. There was also associated obvious changes of a leak with the veins engorging to take up the space left by the CSF, the dura itself becoming thickened. Things that radiologists learn are classic for a spinal CSF leak in terms of changes in the brain. We learned that those don't necessarily have to be present in order for there to be a spinal CSF leak at all. Like in this patient, who these images of the brain, even with me, a hammer looking for a nail, a CSF leak patient, I would not say that this looks necessarily suspicious to me for a spinal CSF leak. In terms of the brain MRI, I don't see diffuse, smooth, circumferential thickening of the dura, the lining around the brain. I don't see the brain sagging downward. I don't see the dural venous sinuses here in sagittal cross section becoming engorged with sort of convex outward margins, but yet they have a humongous CSF venous fistula. These yellow arrows, again, pointing to a long vein that is taking out the dye from the CSF compartment itself, that subarachnoid space. And this is incredibly challenging, particularly for our patients with CSF venous fistula. They don't have if this patient doesn't have the changes on the brain MRI, they don't have the fluid collection on the spine MRI. How on earth are we going to ever identify them? And how wrong have we been for so many years looking for these patients using the tools and pattern recognition that we expected to see? And it just kept getting more and more complicated. This image is from Dr. Lalani Carlton-Jones. And this is something that we're working on together, but I just told you that, we laid the patient on the side down to get that dye to layer densely where we're trying to find the fistula. Well, this patient is laying on their left side down. Here's that dense dye. Here we're looking in coronal cross section as if we're looking directly at the patient facing us. There's that meningeal diverticulum. Maybe you could start to see the beginning of something here, but I'm not sure many radiologists would really say that this is a definite CSF venous fistula. But then she turns the patient to the right side down, and now this vein opacifies. Here it is in another plane, left side down, nothing. Right side down, vein opacifies. This is the exact opposite of what I just told you we're supposed to do to look for CSF venous fistulas. If it's that simple, what are we doing wrong? And the patients in whom we're negative, perhaps we should be doing this exam completely the opposite way. Further, Dr. Madhavan just led a study that we collaborated on with a number of other institutions, looking at CSF venous fistulas that don't arise from a meningeal diverticulum. Here's a beautiful image from him from a photon counting CT myelogram showing this vein opacifying arising from a nerve root complex. This is a nice image because it shows a very small meningeal diverticulum at the level below. These structures are not necessarily pathologic in and of themselves, but they seem to be the substrate from which the CSF venous fistula forms. And so we typically think we're looking for the fistula where there's a diverticulum. And in a patient without diverticula, for example, we should not find a fistula. But that's just not the case either. Here's a fistula arising from a nerve root complex that has no diverticulum. And here's the MRI as well. So every step along the way, we have had to realize that as sure as we are, as expert as we feel, we may be wrong about the things that we hold to be truths. This patient as well, you may not think fits into a spontaneous CSF leak category. She underwent several surgeries for scoliosis and has this large, complex pseudomeningocele that is along her lumbar spine. You can see these lumpy edges here in this coronal 3D MIP reconstruction and in the axial plane here as well. But if you talk to, for example, a spine surgeon who is less interested perhaps in this disease, they may say, but this can't be a leak because it's contained. It's sure it's lumpy bumpy and there was a leak during surgery and we repaired it, but it's contained. There's no leaking. The fluid's all staying here. Well, this patient had a CSF venous fistula arising from this postoperative pseudomeningocele. You can see here in this image, this long vein draining down. And as we scroll through here, you can appreciate this vein coming off of the pseudomeningocele itself. Every step along the way, when there's something in our gut saying, but this patient has the symptoms of a leak, but the rules say that they don't, we have to be very, very careful. It gets more and more relevant. This patient was an 8-year-old girl who had back pain and developmental delay, and she had an MRI of her spine that said that she had a benign incidental meningeal cyst, this very, very large cyst. On a conventional MRI of the spine, it simply looked like that. But on a specialized CSF leak protocol of the spine, we can see that there's not only this large quote unquote cyst, but indeed there is a little bit of epidural fluid, not a longitudinal collection, but trace fluid here. Indeed, during surgery, this did not represent a meningeal diverticulum, but rather herniation of the inner layer of the meninges through a dural tear. And this young person lived with this disease and was told that, this is a benign finding. You have developmental delay. Well, she didn't have developmental delay. She just couldn't sit up in class to learn. Okay. So again, yet another example. And I promise I'll be done with these soon, but I just am struck by these every single day. A patient gets a conventional MRI of the spine that is looking for epidural fluid. And I admit, when I look at this, maybe there's a couple spots here that I'm a little bit suspicious of, but I would not say that there is definite epidural fluid on this exam. Same patient, different sequences, a 3D T2 fat suppressed protocol. We can see there's clearly abnormal epidural fluid in the lateral epidural space, in this sort of epidural gutter, so to speak, here up and down the spine, that is just simply not visible on the conventional sequences obtained at almost every imaging center across the country or even the world. So now we arrive to the sacrum. If you are in radiology, if you're or in medicine in general, and you learn about Tarlov cysts, and we'll talk about what those are, but what we're talking about is meningeal diverticula, outpouchings along nerves that contain CSF that are in the sacrum. Generally, when people say a Tarlov cyst, they're referring to the sacrum. They're essentially benign. These are benign incidental findings. Occasionally they can cause pain, but they do have nothing to do with CSF leaks. They are not pathologic. And also, very interestingly, and I remember Dr. Carroll saying this at a meeting several years ago, when someone said sacral CSF leaks are incredibly rare, they just don't happen. And he said, how could that be? We're taught these two things. I mean, these are accepted as truths. And so when you look at a patient like this, okay, whose terminal fecal sac at the bottom of their dura has these large cystic outpouchings on both sides, very abnormal looking, with these big cysts here, looked at in isolation with the original heuristic of medicine, you would say, well, this is just a benign, complex Tarlov cyst. Maybe I won't even mention it in the report. It certainly has nothing to do with the patient's presentation. But what if I told you that that patient was imaged several months earlier? And when they presented with their symptoms, they didn't look like that. They had a fluid collection because they happened to show up in the ER and get an MRI. A fluid collection that was confined to their lower lumbar spine and their sacral spinal canal. They had one cyst here before, and now they have two or three or four, right? But on this image, you see this one that was existing previously, that was there, but where was this one? It wasn't there.
Hey,
Similarly
Andy,
here, yeah,
so the images on top are early in the leak. The images on
correct.
the bottom are later in the leak.
That's right. 2 months later, the
Now,
patient got
can
another
you,
MRI.
in the middle panel, in the upper middle, can you delineate for our audience what's normal fecal sac and what's epidural and how you tell the difference?
Sure. So it's actually a good comparison because what we see here, and this can be tough because there can be artifacts that, imaging tricks that mimic this, but this dark curvilinear line here that I'm tracing with my arrow, That is the ventral dura itself, cut in cross section so it looks like a line. And it's being displaced posteriorly from the spinal canal, the bones of the spine. And that white here, this is a fluid sensitive sequence, meaning the fluid, the CSF is showing up as bright, is also filling this space here. There is an epidural fluid collection that is actually very ventral in the front of the spinal canal here. And you could see, in contrast, 2 months later, this patient does not have that line anymore. The fluid collection is gone, but they have these cysts. Something has developed in the sacrum, and the fluid collection that was there at the acute onset of symptoms is gone. This patient was taken to surgery after these images and found to have a sacral CSF leak. There was contained, semi-contained fluid collections in the sacrum. Some were lined with sort of arachnoid, the inner layer of the meninges. Others with more of like a pseudo membrane of sorts that were mimicking Tarlov cysts. If this patient did not have the original imaging at presentation, I can almost guarantee you that this would not have been read as a sacral CSF leak. Okay, coming from the radiologist's standpoint, I would love to be disabused of that hypothesis, but I think I'm unfortunately correct. That image is from our paper, our multi-institution paper on sacral CSF leak treatment, and it's not the only example. Here's another one, pre-patch. This person had a patch. They did not have a cyst here. They got a patch, and they did. This one, look at all the free fluid here, out, just sort of pouring out from this sacral CSF leak. This person got a patch, and now they have these cystic collections. Some people, they develop the cystic collections, and they're actually feeling better, but not all of them are. And you can imagine, perhaps there was a minor trauma, for example, in a patient, they fall on a hard surface, maybe there's a little bit of bleeding, they get their own little blood patch, for example, they have a leak, it's incompletely healed, they never get this image on the left. They only get the image on the right. So I want to get into 3 key points about why I think that we are missing sacral CSF leaks currently, and hopefully that we're getting better at it. But things that we could focus on going forward that you could take away and sort of help advance this part of our field. One is that classic historic teaching, which I mentioned. 2 is something very simple that we could all change quite easily, which is the field of view on our MRI. And 3 is the technique we use when we perform myelography. And I mentioned this earlier, but this is a patient who did not have any pre-image, okay? There's no image showing an epidural fluid collection, but came to me because of a syndrome that sounded like a CSF leak. It has this large, abnormal, multiloculated cystic collection in the sacrum. I could tell you that if I gave you these options and I said, what is the most likely thing for this person to have in the body, in their documented medical record? I think that the most likely thing is that these are quite impressive. They might be mentioned in the body of the report, meaning not in the sort of conclusion, but the descriptive findings. I don't think that many places would actually mention these in the impression, that conclusion of the report. I think it's quite possible that some places might not even mention these at all because they're taught they're benign. And I doubt that anyone would really emphasize these as possible pathology unless there was a very leading clinical history.
Andy, let's jump in there and just let our patients know, like, what's the difference between putting this in the body of the report for a radiologist or the impression. Like, when I order an MRI and it goes to you and you read it, let's say it's not you, let's say it's a radiologist who is well trained but isn't as tuned into what we're coming to understand is the importance of these sacral collections. The body of the report is going to have a lot of robotext in it, which is kind of text that's in every report talking about what's normal. And then there might be a couple of sentences of things that are not necessarily important, but the radiologist saw and wanted to mention in the report. And then at the bottom of the report, there's something called the impression, where there's maybe 3 bullet points where it says something like either CSF leak seen or no CSF leak seen, and and there might be one or two other sentences talking about things that are really important. And I don't want to give it away to you as a radiologist, but many doctors, they really just go right to the impression and that's what they read. And so what's in the impression of the report is like the whole game. You could hide a cancer from a doctor by mentioning it in the report, but not mentioning it in the impression, right? And I think there's probably lots and lots of lawsuits related to exactly that kind of thing, because people don't read the whole report. But I think that the if you had to guess, having sat in the room where these things were dictated, you said, which of these things this might be read as. What do you think most likely is going to go in the impression of this MRI?
Yeah, no, you're exactly right. That was a great characterization. I teach our trainees that anything, the impression is trying to answer the clinical question. So ideally, an order for an MRI comes with a question. It says, "I'm worried my patient has a spinal CSF leak. That's why I'm getting it." It doesn't say something like pain or, but unfortunately, particularly in the emergency setting, we don't always get that. And so you're trying to answer the question and then also address salient issues. Whereas in the body of the report, you're almost like an insurance adjuster. There's this, there's not this, this looks okay, etc. But yeah, I mean, I think I would say that most likely, perhaps a plurality would be the option A here. Is that I think these are quite impressive. I think that most of the time, smaller Tarlov cysts might not even get mentioned at all. But in this particular case, potentially A, followed by C, then B, and then D. That's my guess.
Yeah, and I think that the discrepancy between the two, maybe it's useful for patients to know. This is why when they send a referral to you or send a referral to me, we're almost not interested in how the report was read by the reading radiologist, because there's so much variability in how those kinds of things are talked about. We always want to see the images, right? There's
Yeah,
there's we never we you know it's the report
yeah,
is never enough.
absolutely.
Yeah.
But also I'll say this too to my fellow radiologists. Like I do not feel these things that I've learned have been based on the amount of times I've been wrong, myself. And the radiology is unique in that everything that you are doing as a doctor is literally documented forever, right? Every mistake you make, a small slip up, perhaps during a procedure or a surgery that may not be captured and documented for eternity. That's not how it is for radiologists. If you miss something, that report's there and you missed it. So there's a humbleness to being a radiologist. There's a saying that the radiologist who doesn't miss things hasn't read enough studies, right? I mean, it's part of it. And so the way that we address this is not through necessarily criticism or mocking people, but through education on trying to all get better together.
Yeah.
Um, just quickly, these are things that I think this issue on the right should make us all pause and wonder why this is even a mystery that CSF leaks in the sacrum can happen. But when we are standing upright, it is well documented that the CSF pressure is the highest in the lowest part of the spine. I told my patients, just like at the bottom of the ocean, right? The pressure is the highest. The water is stacked on top of itself. We know this. This is under the greatest hydrostatic stress of all of the dura. And at the same time, we have histologic evidence that as we move caudally or down in the spine, the dura becomes thinner, more delicate. If you talk to spine surgeons who work in this space, they tell you, this is a very delicate space. I don't want to go there unless it's really a good idea for the patient. And so we're dealing with delicate dura at the highest hydrostatic pressure in the spine in the upright position. And somehow we have come to the conclusion that this is a rare phenomenon that just never can happen. And it just makes us sort of stop and say, well, wait a second, maybe this isn't some crazy discovery we need to make, but instead we need to sort of reinvestigate from first principles what we're doing here. This is a beautiful image from Dr. Lutzen, who I'm going to credit more soon because I really think he's been a pioneer in this space from Freiburg, Germany. But this is something that he really emphasized to me and in our paper together was what are we missing with routine coverage if somebody orders an MRI of the lumbar spine, which is a very common order, they may not even get the whole sacrum. This is the same patient image twice. Okay. The second time, Dr. Lutzen said, well, wait a second, is there something a little bit funny in the corner of this image here? And this patient had a huge multiloculated extradural CSF collection in their sacrum that simply I would not fault any radiologist for looking at this image and saying this is normal because it did not capture the abnormality. We are now making sure that when we perform an MRI CSF leak protocol of the spine, that we are including the entirety of the thecal sac, all the way down to the terminal thecal sac in the sacrum here. This is something that everyone can do, whether you're a leak center, anywhere, right away, even if you don't have a CSF leak protocol, is part of your routine sequences. Just capture all of it, right? Open up the field of view a little bit more. That is not something that is hard to do and that we could do right now. So this is an important point. And so, we're the drunk guy looking in the street. We're looking what we can see. We just simply can't see the abnormality, right? The keys are right here, and it's no fault of us in this case, but it is because we didn't design the protocol appropriately.
Before
One of the
before I get, you were good and you're saying that you have you're getting that on everyone. Um, you've been getting the sacrum on everyone for how long now? How many years back? Because you don't want people contacting you that were seen last year saying, "Hey, by the way, did you do this for me?"
I mean, it's hard to put an exact number on it, but for at least a year and a half or so, and anybody who I'm actively caring for who we haven't figured it out yet, and I don't have images of the sacrum, I'm asking them
All right.
to get a new study.
I'm just going to tell people not to message me about this. We've been looking in the
I'm gonna
sacrum
I'm I'm gonna
on
provide Dr.
everyone
Carroll's
forever.
cell phone number and home address at the end of this, so you can send him all your messages about the sacrum
Yeah.
when we're done. There's a similar concept of myelography that's perhaps a little bit more complex, but it's actually not, right. I mean, think about it. We are puncturing patients in the lumbar spine and then tilting their head down and moving the dye up to the head, and then looking for a CSF leak, and we're not finding one, and we're saying there's no CSF leak. I mean, that this is not a complicated concept, right? I mean, we should be looking everywhere in the spine that there could be a CSF leak before we are ready to say that the study is negative, certainly, right? And frankly, it sounds like it might be hard to do. Do we need to, you know, I mentioned this device that I use to tell patients. Do I need to reposition them just so, or kind of change the angle? But Dr. Ian Mark at a recent conference made this point. I thought it was a very good one. That technically, if we just simply puncture low, like at L5S1, for example, and before we raise the patient up, inject our dye, and we take a picture there, you will flood the terminal fecal sac with contrast. Almost every case, with some variations, if there's different anatomy or very bad spinal degenerative disease, if you just take a second, you do your first injection, and before you raise the patient up to get the rest of your normal exam to move that dye down towards the head, you just take a picture of the sacrum, you'll get these images. It'll take 30 seconds to get this set of pictures, right? And this is something that we should be doing deliberately to make sure that we are covering this area. How low can we puncture? Can we get dye into the sacrum first without having to puncture them again, without having to bring them back because of an incomplete exam, etc.? And when you do that, and this patient, I actually did have them sort of tilted down. So the dye was moving down. I was very, very suspicious of a sacral CSF leak. You can get an image that looks like this. Here is the scout image. It looks like an X-ray because it basically is with the CT scanner planning where we're going to take the pictures. We see the dye is really accumulating down low here. And this is gradient, very dense gradient at the tip of the thecal sac and the sagittal plane here. And we could see very early extravasation, that leaving of the dye through a hole in the dura right here, okay? The black arrow is pointing to a nerve root here, and then the white arrows are showing where this dye is extravasating, pouring out through the hole. I can pinpoint for my treatment or for my surgeon exactly where that leak is.
All right, Andy, go back for a second. So one more slide. All right, so we're going to get a lot of questions, and all of our colleagues around the country are going to get a lot of questions about this because everyone who watches this, who's had a lateral decubitus CT myelogram or a lateral decubitus digital subtraction myelogram. Lateral decubitus, for those who don't know, this is the medical term for lying on your side. Everyone who's had a myelogram lying on their side is going to now be wondering if they didn't have a CSF venous fistula found. And remember, you and I know we've published that 4/5 of the people who have postural headaches and other symptoms of CSF leak will have negative imaging, 4/5, right? So we know that we're missing a lot of these with imaging. You've now started to show us how the sacrum may be an important place where we've been missing some of these. And so it is totally reasonable for those people who have had negative imaging evaluations and are still suffering to be saying, hey, does this become an action item to me? Do I go back to Dr. Carroll now and ask them, did they look in my sacrum? And so let me throw out what the obstacles are to this now and what you think the path forward is. So a couple things. While you've shown a dynamic table here, because you've created a device that can tilt people one way, tilt people another way on a CT scanner, our audience may not know that the CT scanner is not built to do that. The CT scanner has a flat bed that goes out, it comes back, it doesn't tilt up, it doesn't tilt down. So the CT scanner itself that's in every hospital around the country is not built in a way to facilitate tilting up and tilting down. And so the mechanism that most people had been using and that you were using, and you were using a different mechanism until a couple of years ago, to do this is a simple foam wedge. So Mark Mamluk, one of our colleagues, really helped advance the field by publishing a protocol talking about how to do this kind of myelography by injecting in the low back while people are lying on a foam wedge so that their head is tilted down, and the contrast would go from where you injected it to go down and cover, the 90% of the spine above the sacrum. If someone's lying on a wedge like that, it doesn't matter if you're going to inject at L5S1, you're not going to cover the sacrum. And then you've got a second problem, which is you and I have now looked at a couple of things together where the sacral CSF venous fistula can be so subtle, even if you got contrast into it. I don't know that there's a handful of people in the country that could diagnose that. You really have to be looking at it with incredible detail, looking at an early phase and then a delayed phase, and comparing. Is this thing opacified here? Is it bright here? Is it bright when we look 30 seconds later, or did it clear? I think throwing this out there. I can tell you, everyone who's had this at Stanford, we have not looked in your sacrum unless we brought you back for a totally separate procedure so you could be placed backwards on that foam wedge to look at this. And we've started doing that to some people. What do you tell to people? I don't think there's a lot of places in this country where someone can get this kind of evaluation in their sacrum at the same time they're getting the rest of their spine looked at. How many places do you know of that are currently offering patients who they're doing lying on the side myelography to a realistic appraisal of the area above the puncture going toward the head and a true evaluation below that site down into the sacrum?
I don't know the exact number, but I know that there is an earnest interest and desire to start looking at this. Like I mentioned, Dr. Mark from Mayo Clinic mentioned this. There was a paper recently by their group talking about, CSF venous fistulas at sort of atypical, quote unquote, locations, including at the top and bottom of the spine. I think, probably not a lot. And frankly, when I look at my own myelograms from 5 years ago, I'm horrified. I feel like I failed my patients who are negative. I want to bring them all back, right? I mean, we have so far to go, and yeah, maybe I think I'm great with my table right now, and in 2 years, I'm going to be like, I can't believe that I was doing it this way. and not, some better way, right? This is a constant. We are trying to catch up desperately for our patients, and I think that this is a good way to do it right now. I'm very happy with this. I think it's a good way to look with the things we know. But I'm sure there's an even better way. I'm sure that this is going to be, we're going to laugh at my silly table in a couple of years and say, remember when Callen had to build something to move the eye up and down someone's spine, and that we were acting like, whatever. That's my goal, right? Is to make the novelty of this conversation obsolete one day.
Fair,
So
fair to characterize this as something that now all the authors of that paper that you published, which had authors from the best centers around the world, are now thinking this is something we need to start thinking about doing, but maybe only half of them have truly implemented routinely, if that. And the rest of the world is trying to catch up with the meaning of this and say, like, how are we going to change our workflow? Are we going to do extra punctures to people to bring them back and do a separate myelogram with them head up versus head down? Or are we going to try and do the myelogram we've been doing with them head down and then try and reverse them to get them head up? I think everybody's finding different ways to look at the logistics of this. It's a little hard to know how
yeah,
to advise patients right now who are suffering, right?
totally. We just talk it through with them and share the honesty of our imperfection and sort of the fact that we're not doing a good enough job. I could tell you, I don't know the exact protocol that every place is doing to change it. I can tell you that I can say honestly that I believe that every single one of those co-authors is thinking about this in earnest, and frankly, that anybody doing this work is thinking all the time about the patients in whom they couldn't find a leak in. I'm showing all these really cool cases of leaks I found. I've done a lot of negative myelograms, that keep me up at night when I know the person is desperate for an answer. And so, the doctor taking care of the patient suffering from this does not know what the patient is going through because they're not living that experience, but they're maybe a runner-up in terms of frustration because we didn't go into this field to do nothing for people and give them punctures and radiation and have them go home with no answers, right? This is a failure of us to not find the answer. And if not to find the answer related to this specific question, to give them an alternative explanation, which we are also unable to provide, right? So I can say that for sure that I believe that every doctor working in this space wants so badly to be doing better for their patients, and I'm glad that everyone is taking a different approach because it's going to take many different ideas, a diversity of ideas and thought to get where we need to go.
All right, I interrupted you. Let's keep going.
It's okay. I'm guessing it won't be the last time, but we'll see. We'll see. Um, so I want to shout out Dr. Nicholas Lutzen because he has been on to this before, frankly, I think most of us. He published this paper in 2023 where he was really the first, relative, it's not large, right? It's nine of patients in a series of 149 who had sacral CSF leaks. And these patients, but, he was describing them specifically. He was calling it out. And frankly, at the time, I think that most of us would have seen this number as big, 6%. I mean, that's more than I have at the time, right? Because we're not looking. But he described a couple really important things. He said, some of these, but not all of them, have these Tarlov cysts or meningeal cysts. But really importantly, he said, look, we need to at least image these sacrums on MRI. And that same thing I showed you before. This is an easy change. We can at least identify some of these people in this way. And he also said, some of our patches, perhaps we should be thinking about getting the patch down into the sacrum. And I'll give you credit for this, for saying, when you reach a sort of quote unquote dead end with the patient, maybe try patching in the sacrum because in some people that actually helps, even if there's not a sort of direct smoking gun, so to speak. But he really called these two things out. And I give him a lot of credit for that. He approached me at a meeting in Amsterdam and said, listen, we need to write up a multi-institution case series on this. So a lot of credit to him for his leadership here. And here is that study. And I want to point out something again to you, okay? 11 centers across the world, 54 patients. That is nothing. I mean, it's incredible how few we were able to scrape together with all of these places in the volume that everyone's doing. But there's some important things that I want to take away because we've been talking about a lot of sort of doom and gloom, we've been failing, etc. There's actually some good things about sacral CSF leaks, believe it or not. So this number right here, I'm going to put this into context soon with other work we've done on improvement after patching. This sounds low. It is low. 56% is not close enough to 100%, but it's actually pretty high in the context of other types of CSF leaks, well, particularly dural tears, I should say. And nearly half of them did have resolution of the CSF on follow-up. We tracked both the imaging resolution and the clinical resolution. This was an incredibly enriched cohort of women, which is quite interesting because do you know what else has a very high predominance of women is sacral Tarlov cysts. Okay, so I'll get off my soapbox eventually, but I can't say this enough that we need to be paying more attention to this. Most of these individuals didn't recall a specific trauma. Some of them had minor trauma, but this wasn't like they were in a horrible car accident or something like this. It was sort of basically spontaneous, falling under that category. And I want to contextualize that for you in the other multi-center studies we've done on patching or percutaneous treatment, I should say, of spinal CSF leaks and sort of the key takeaways. So you could think about this globally overall. And so when we looked at CSF venous fistulas treatment with fibrin glue, the patient telling us that they are completely cured of their symptoms occurred in 59%, or close to 60% of individuals. We found that really the brain MRI and the clinical improvements seemed to track. We found some patterns with regards to ejectate spread. I won't go into depth on these just in the matter of interest of time so we can get to questions at the end. With ventral dural tears, it was a lot worse. Complete resolution of symptoms in patients after getting a traditional patch or getting a patch for a ventral dural tear was only 31%, and that their epidural fluid collection really was only resolved a quarter of the time, and that it was dependent on whether the fluid collection was unorganized or organized. I'm going to show an example of that in the sacrum because it's relevant here. When the collection was organized, their outcomes were much worse, and that a certain type of patching really improved outcomes for those patients. Lateral dural tears in another multi-center study, we found complete resolution a little bit modestly higher, 35%, partial resolution 48%, none in 16%. We could get the SLEC, that epidural fluid collection, to resolve at about a quarter. And we found that when the arachnoid pouch, that herniated inner layer of the meninges, was really pooching through that dural tear and very obvious on the MRI, that portended poorly for the patient's outcome. So when you contextualize the sacral CSF leak patching data, it's actually quite good. If we could just start seeing them, we could actually help more people, at least that we're helping with, our other CSF leak types, theoretically, that we could, get complete clinical resolution in over half of people if we just patch them where their leak is, that we can resolve the SLEC at a higher rate. And again, we need to pay attention to this unorganized or organized appearance. Another interesting thing, this wasn't anticipated necessarily, but we did ask every center to provide data with regards to did they use a dynamic CT myelogram or a DSM to look for the leak, and did they feel that they precisely localized it with that study? And it was overwhelmingly in favor of dynamic CTM for finding the leak. So this was, a strong signal that perhaps for these types of leaks, using CT for your technique is important. I just want to quickly show for everyone some examples of what some of these patches look like. Here's an example of a transforaminal patch from Dr. Lipson that you could see here on the pre-image. We see this organized fluid collection. There is fluid outside of the intradural compartment. It's this stuff here, but there's well demarcated edges. It's not flowing out kind of into the soft tissues. This patient received a patch through a neural foramen, one of the windows where the nerves exit the spine. We could pass a needle safely into there and place that patch material into the epidural space itself. You could see that post-patch, the majority of this fluid collection is gone, but there is this remaining loculated sort of component here that is sort of the clue that there used to be a CSF leak here. Again, some of these patients are feeling better all the way or partially, some of them are not. Here's a really, really important patch. And again, shout out to Dr. Carroll for emphasizing this to me years ago, saying, you should be using the sacral hiatus, the caudal epidural space for sacral patches more. This is a natural anatomic opening, a bony opening at the very tip, the bottom of our spines that almost everyone has. Here's my needle right here in this patient doing a dye test. The fecal sac, the dura, ends just about here. So we have plenty of room of fat. It's very safe. I'm not going to accidentally puncture the dura. I'm doing a test injection to make sure that my dye is moving up how I want it to. As you can see that after I inject the patch, it's really moving nicely up into the sacral canal, all the way up into the lumbar epidural space as well. This is a very, very nice technique to get a good sacral epidural patch if you're less familiar, for example, with the transforaminal one. In terms of outcomes, again, similar to CSF venous fistulas, for those who had positive brain MRIs or burn scores that were, modest, if those dropped, that seemed to track with their symptoms improving as well. That unorganized baseline morphology, and I promise I'll show an example of that in just a second. If it was unorganized, it was much better. And that if the fluid was sort of just kind of pouring out everywhere, we could catch them early on in the disease course before it became loculated and encapsulated. This was much more likely that we were going to fix them, so to speak. But things like, did we use blood? Did we use glue? Did we use 20 cc's or 30 cc's? Did we go transforaminal? Did we go caudal? Those things weren't independently associated with outcome. Now, I'll say that this is a little bit tough because these are all highly, quaternary, highly specialized CSF leak centers, kind of choosing a slightly different thing. It's hard to know, this compared to sort of quote unquote traditional patching writ large. Would this make a difference? But nonetheless, in this study, it was not. And again, dynamic CT myelography was localizing the precise site of leak 75% of the time compared with 31% of the time on DSM. This was an important sort of interesting, unexpected finding from this study. Here's an example of unorganized versus organized. What I mean by that, I'm scrolling through an MRI here, and you can see as I do so that there's fluid signal. This is what the red arrows are pointing to, just insinuating out into the retroperitoneum in the presacral space. It's not just confined in these loculated sort of bubbles like we see here in this person. We see these loculated extradural fluid components outside of where the dura is, but they're not. There's no fluid signal, feathery fluid signal out around here. Okay, this appearance, the same sort of paradigm in ventral dural tears, very important. Probably a marker of that membrane formation with disease chronicity. We don't know if this is accelerated by patching, for example. It very well may be, but it's important for counseling our patients. We say, look, I see this. I tell a patient, frankly, look, there's a good chance. Like, I'm so glad you're here. Let's patch right now because I think there's a good chance we could fix this. Once we get here, I'm frank with them. Look, I think that our chance is going down. We might have to try more than once. Perhaps surgery's in the cards down the line. I just want to touch on our conclusions here and wrap up, and then we'll kind of open it up. In conclusion, sacral CSF leaks, these are right now, capital U, uncommon, but they are real. And I think that there are some basic, fundamental, first principles things that we can address so that we can recognize them more. And if we just simply look at the sacrum, that perhaps we will see more of them.
How confident are you?
I am absolutely confident that
how confident are you that sacral CSF leaks are uncommon?
I am willing to be wrong in either direction on any of the statements I make here or at any time. I think that they are not
saying,
uncommon.
like in your heart of hearts, what do you think the chance is
I think it's low.
that among people who have leaks, sacral leaks are actually common?
I think that it's low, but at the same time, if we get tunnel vision in the direction of it is this, then we are falling victim to the same bias that led people to miss this, right? We have to be open to the idea that I think this is an important testable hypothesis with preliminary evidence showing that it is anatomically feasible, at least true in some cases that we've now demonstrated counterfactually within a patient to mimic another thing that we call normal. But we have to always maintain the idea, the notion that I could be wrong and they are rare. It's possible. I do lots of negative myelograms, right? And I don't want people to get the idea, oh, well, simply if they just did this, then there's my answer and I'm going to be better. I still get frustrated. I still can't find the leak in a lot of cases, right? It's important to keep in the back of our mind.
I would feel comfortable saying they're uncommon, but saying my confidence that they're uncommon is low.
Yeah, agree.
Yeah.
And we know that part of that is because these are mimicking things that we are calling normal. These Tarlov cysts, these meningeal diverticula. And so we need to know the clinical context of a patient. Sure, a patient who is taking part of a research study as a healthy participant who has zero symptoms and happens to have a Tarlov cyst. We're not going to go do surgery on them for a CSF leak. Of course, there is such a thing, as this not being important, but we need to know what is going on with the patient before we describe something in a report. And that we are learning more and more about the treatment outcome tracking biology here. That we need to not just say, is there a collection, but what does that collection look like? Where is that in the patient's disease course? How does it fit in with the whole clinical picture and story? With that,
Andy,
I want
go
to say,
ahead.
let me get out my personal sob story for a second. I want to dedicate this and a lot of the work that I'm doing right now to my dad, who I lost this past winter. He was a radiologist too. He did obstetric ultrasound, and he was very disillusioned with academic medicine and radiology in particular towards the end of his career, and almost encouraged me to not go into this. He said, the questions that people are asking now, it's all these esoteric things. Like, what about just helping patients? Asking simple questions. And I feel very connected to him when I do this work because these are, while it is really a shame that we are so behind on this science. The questions that we're asking are not, can we take a mouse model and slice a gene? We're asking, why are we unable to help these people? And there's something in front of us that we're missing. So, thank you, Dad. I feel connected to you. Thank you all for bearing with me for that, and thank you to my team of incredible colleagues at the University of Colorado who I get to work with every day.
Andy, it was great meeting your dad before he passed. Um, as you know, my wife, an obstetrician, was trained with your dad's textbook, and she got a thrill out of meeting him as well. We've got a bunch of questions here. I'm going to read them out. For the ones where the answer is no or we don't know, maybe we just process those quickly. So I'm not going to read the names of anyone. There's a question here. Is there a plan to bridge the gap between symptomatic Tarlov cysts and leaking cysts? Personally, I had a Tarlov cyst surgery to reduce cysts and close leaks, but I think she meant to say fell. I fell in between two separate conditions, and it felt extremely hard to navigate. Do you want to jump in on that one?
Yeah, I mean, look, there's going to be what I was hoping to try to echo was that a story like that, and so many people's stories is I don't know. I'm suspicious that there is something that we're missing with our mental model of this. And yeah, the plan is webinars like this, the more conversations about this, more research. That one patient who thinks maybe I should have another image, that one provider who may say, well, maybe I should start including the sacrum. That's the immediate plan. The first step is just simply thinking about it more. And then we can start to get the resources, the sort of attention that this disease deserves to start asking more complex ones to do the more rigorous science that it needs.
All right, I'm going to get the next question. I'm going to leave the institution out from this question. I was diagnosed with a leak about 15 years ago and sealed at institution X from a spinal tap. But I've been on Diamox since then with horrible neck pain and headaches. Living in CO, the weather does me in. Could it be possible I'm still leaking? My headaches are not positional. I'm going to jump in
Eh,
on that one.
yeah, you go for it.
Yeah, you could clearly still be leaking. It's really hard when you had a leak 15 years ago and you were sealed. If you're having horrible neck and head pain and it's not positional, it might be high pressure, but it might be low pressure. Probably time to go back to an expert center. Next question, or unless Andy, any disagreement there?
No, no, I would say, I think I'm not sure, Bahrain, are we gonna run out of time and dead end here? I don't know how best to handle this. We obviously we're too loquacious, but
No,
the
if you're okay taking a few more questions,
okay.
We don't
we
have
can
that
keep
many.
it
I
going.
think we can get through a lot of them if we give this another 10 minutes. Andy, what do you say?
All right, let's do it. Yeah.
All right.
Thank you.
Oh, Andy, you're gonna love this. Um, can orthostatic headache occur from jugular venous outflow obstruction or compression rather than a CSF leak? For example, could positional changes in venous drainage explain headaches that improve when lying down?
Do you want me to take that?
Yeah, go.
I think that it is absolutely plausible. There are some people who very strongly believe that. I think that I've yet to be compelled by the existing published evidence that that is the major driving force for the way it is being described. And I admit that that is framed by a bias I have seeing patients who've had that addressed surgically or endovascularly and are still symptomatic. And I'm not seeing people who are skipping away as happy as could be. So that is a bias that I have in terms of my practice. There are some physiologic and anatomic changes when we change posture that result in the jugular veins compressing naturally when we're in the upright position, shunting blood into the vertebral venous plexus. So it's hard for me to wrap my head around that being a sole driver of orthostatic headache when there's a natural tendency for them to completely collapse. And then again, if it was as simple as simply just needing to decompress everyone's jugular vein and all these patients of mine who are suffering would be better, then I am willing to go down that intellectually. I'm surprised at the paucity of despite the sort of widespread adoption of this philosophy and sort of the robust practice of this across the country, at least here in the States, that there's not more larger series demonstrating its efficacy. I'm a little bit surprised at that. And when and if that happens, I'm absolutely willing to entertain that as a more common cause.
I'm going to jump in and say there's really two questions here. I'm going to give my opinion. Can orthostatic headache, meaning a headache that's worse when upright, come from a jugular venous outflow obstruction or compression? I'm going to say no with low confidence. I'm open to seeing evidence that shows that it does happen. I've seen zero evidence that jugular venous outflow obstruction causes the same kind of postural headache a CSF leak does. So I'm going to say zero. I'm going to say no. But again, open to seeing evidence that shows me I'm wrong on that. In contrast, the next part of that question was, for example, could positional changes in venous drainage explain headaches that improve when lying down? That part of the question, the answer is clearly yes. It's clear that certain kinds of venous stenoses, venous narrowings in the major venous pathways in the lower body and in the thorax, in the chest, can shunt venous blood into the epidural space, and that some percent of people with postural headaches appear to have that physiology. And we don't know if that explains 2% of people with postural headaches or 90% of postural headaches. Everyone in the field is interested in knowing more about that. That is considered real and of active interest. The jugular outflow thing, most of us wonder to what extent it might cause high pressure, but I don't think there's many people who think right now that jugular venous outflow obstruction causes headaches that are better when flat. Again, most of us are open to being shown data that could show we're wrong. Let's see, we get some appreciation for mentioning Tarlov cysts. Here's a question. I had a fibrin patch. They don't say where in their spine. And within 10 days, I had severe sacral pain. I had never had it before. The radiologist told me it could be related, but after my own reading, I realized this either caused or exacerbated Tarlov cysts. I'm wondering now if the leak I've been dealing with has always been in that location. What is the best imaging now and where to focus to see Tarlov cysts? I had a full spine MRI recently and they didn't comment on it, but I'm not sure it looked at the sacrum or even knew what to look for.
I would say that the best thing, the most valuable thing in radiology is old gold, priors. If you have an image close to the onset of your symptoms that shows that you did not have a sacral Tarlov cyst, and now you do, to me, that is that you had a sacral CSF leak, and then now it is an encapsulated, pseudo-encapsulated collection like we showed here. So it's not getting a new one now with some special protocol. And of course, it's if you didn't have it, you didn't have it. But it's the comparison, the side-by-side comparison. And I want patients to be empowered to look at their own imaging, but there's lots of weird nuances, and if you could find a doctor that you could trust that could sit there and look through that with you, to make sure that because the path you may go down could be invasive, that is what is happening here, then I would say compare early to as recent as possible.
We've had a couple of patients where we've patched them in their thoracic spine. One I'm thinking of in particular who had a nice, well-documented CSF venous fistula in the thoracic spine. I had originally thought that this patient was leaking in her sacrum because she had very large Tarlov cysts in her sacrum. And I thought, oh, she must be leaking from those. She had a myelogram, clear CSF venous fistula, not in the sacrum, up in the thoracic spine. We treated the one in the thoracic spine. She went into high pressure immediately, a day later. And when she was in high pressure, she had new sacral pain that had not been there before, with some radiation into the legs. And when we re-imaged her sacrum, her Tarlov cysts appeared to be bigger. Our interpretation of that was we pressurized the system, and that pressure distended her existing cysts. We've seen that dynamic in a couple of other patients, but this one particular patient was just each part was very clear cut. Have you seen that kind of dynamic? Do you think you've seen that kind of dynamic?
Absolutely. And one thing I didn't touch on today is the sort of other side of the coin in terms of what, let's call them real Tarlov cysts could do, which I do treat as well, which is pain, right? I mean, let's say that there's a one-way valve, there's fluid accumulation, and there's impingement of a sacral nerve. In the absence of headache or anything CSF leak related, there is a safe and good procedure we could do to sort of take the fluid out, obliterate that with fibrin glue. And so it stands to reason that if you could have one-way accumulation of fluid and hydrostatic pressure impinging upon a sacral nerve root, and we also know from recent work from Freiberg that patients who have been sealed from a sacral CSF leak will have an increase in total volume of their CSF compartment, then it absolutely stands to reason that what you just said could very well be true, that they, after in the post-sealed period, now have increased accumulation of fluid within a structure that is intimately associated by definition with nerves and could have pain. I mean, I think that's a very reasonable hypothesis.
Here's an easy one. Why would a diverticular cyst up at the top of the spinal cord, let's say C1, C2, or C7, why would a diverticular cyst at the top of the spinal cord show contrast if pressure at the top should be negative?
Well, because we're tilting you upside down for the exam.
There you go. We still get
That goes
contrast
down.
flowing up there.
So Dr. Carroll, if we can take one more question. I know for the sake of time, you both have to leave, but maybe we can take the questions and then hopefully answer them at another webinar or see if
Here's a question. How would a spine MRI be ordered to include the sacrum? Would you have to specify stars to include the sacrum as part of a lumbar MRI? So it's really, the question is, how do you make sure your MRI gets the sacrum?
If you want to, I mean, so, depending on how your hospital does billing or coding or what have you, I mean, there is an MRI of the sacrum. That is an order that is done. I think that it reasonably, you could include the sacrum. At least the sacrum is the bone, right? The sacral bone. And so you don't necessarily need all of the sacral bone. What we need is the whole thecal sac and nerve roots, which extends into the sacrum. And so, you either could say in a protocol for a lumbar spine, please include the entire sacrum or thecal sac, or if you wanted to be 100% sure, but perhaps have a little bit of overkill, order MRI lumbar spine and MRI sacrum. Now you're going to get some extra bone in there, but that would be the two ways to do it and sort of guarantee at this point.
All right. Andy, we didn't get to joke around as much as I had hoped that you and I would be able to do.
Well, I certainly wasn't joking when I mentioned the address and cell phone number thing. So I'll just throw that in the chat right now, and then we can.
Can we
thank
please
you so much, Barry.
organize another webinar so we can have you and have hear your jokes.
Yeah,
about
Andy and
that.
I have been kind of batting around the idea, not seriously, but just from time to time mentioning like doing a podcast where like we take a paper and we go through it and what did you think about this? What did you think about this? Maybe get the person on the phone or something and heckle them about why they didn't do this or why they did do that. To make some education maybe entertaining. You know, it competes. The idea competes with all the other good ideas. So we'll see. We'll see if that
Well, a
ever happens.
podcast with both of you would be great. So before we leave, I just want to thank you both again on behalf of everyone at Spinal CSF Leak Canada for generously sharing your time and expertise with us today. We had about 300 people who registered for this webinar, so it reflects not only the importance of this topic, but also your expertise. And also happy Canada Day to our Canadian community, and happy 4th of July to you both and all of our American community. Thank you everyone for joining. And again, thank you for
Thank you
your
for the
time.
great work you're doing, Baharay.
Yeah,
Thank you.
great job. All right. Bye, everyone.
Thank you very much.
Bye.
Love your t-shirt, Dr. Callen.